Welcome to our deep dive into the critical neurologic conditions that shape pediatric practice. Today, we turn our attention to one of the most common and consequential neurosurgical challenges in children, hydrocephalus. This condition, often simplistically referred to as water on the brain, is far more complex than its name suggests. It is not a single disease but rather the final common pathway of a diverse group of conditions that result from a fundamental imbalance in the circulation and absorption of cerebrospinal fluid. Its clinical relevance is immense. Timely diagnosis and appropriate management are paramount to prevent irreversible brain injury, preserve cognitive function, and optimize a child's developmental trajectory. In this episode, we will embark on a comprehensive journey through the world of pediatric hydrocephalus. We will begin by exploring the elegant physiology of cerebrospinal fluid dynamics, understanding its normal production, circulation, and absorption. From there, we will dissect the pathophysiology, clarifying how this delicate balance can be disrupted. We will then meticulously detail the clinical presentations across different age groups, from the subtle signs in a newborn to the more overt symptoms in an older child. We will cover the complete diagnostic workup, emphasizing the nuances of modern neuroimaging and differentiating hydrocephalus from its many mimics. A significant portion of our discussion will be dedicated to management, providing a highly detailed overview of both medical and surgical strategies, integrating the latest evidence and critically examining the pros and cons of shunts and endoscopic procedures. Finally, we will explore advanced insights, including special considerations in post-hemorrhagic and post-infectious cases, current controversies, and areas of ongoing research. To truly understand hydrocephalus, we must first appreciate the remarkable journey of the cerebrospinal fluid, or CSF. Think of the CSF system as a sophisticated, dynamic hydraulic network within the central nervous system. Its primary functions are to provide mechanical buoyancy and protection for the brain, to regulate the chemical environment of the neurons and glia, and to serve as a medium for transporting nutrients and clearing metabolic waste products. The CSF is formed primarily within the brain's ventricular system by a specialized tissue called the choroid plexus, which is located in the lateral, third, and fourth ventricles. While the choroid plexus is the main production site, a smaller portion of CSF, perhaps up to 25%, originates from extrachoroidal sources, such as the capillary endothelium within the brain parenchyma itself. The production is an active, neurogenically controlled process. In a normal child, approximately 20 milliliters of CSF are produced per hour, leading to a total daily production of about 500 milliliters. Because the total CSF volume in a child is only about 50 milliliters and 150 milliliters in an adult, this means the entire CSF volume is turned over several times each day. Once produced, the CSF embarks on a specific, unidirectional circulatory pathway. The journey begins in the two large lateral ventricles. From here, the fluid flows through two small openings called the foramina of Monro into the single, centrally located third ventricle. Next, it traverses a very narrow, critical channel known as the aqueduct of Sylvius, which is only about 3 mm long and 2 mm in diameter in a child, to enter the fourth ventricle, located in the posterior fossa just in front of the cerebellum. The CSF then exits the ventricular system into the subarachnoid space through three openings in the fourth ventricle, the paired lateral foramina of Luschka and the single midline foramen of Magendie. Once in the subarachnoid space, the CSF circulates down around the spinal cord and up around the brain, flowing through the basal cisterns at the base of the brain and then superiorly over the convexities of the cerebral hemispheres. The final step in this journey is absorption. The bulk of CSF is absorbed back into the bloodstream through microscopic, one-way valves called the arachnoid villi, or granulations, which project into the large dural venous sinuses, most notably the superior sagittal sinus. This entire process is driven by a delicate pressure gradient. The intraventricular pressure is normally slightly higher than the pressure within the venous sinuses, facilitating the continuous, passive flow and absorption of CSF. Hydrocephalus arises when this elegant system breaks down. At its core, it is a pathological state characterized by an imbalance between CSF production and absorption, leading to an abnormal accumulation of CSF and subsequent enlargement of the cerebral ventricles at the expense of the brain parenchyma. This leads to a rise in intracranial pressure, or ICP. The mechanisms of this breakdown allow us to classify hydrocephalus into distinct categories. The most common form in pediatrics is obstructive, or non-communicating, hydrocephalus. In this type, The flow of CSF is blocked at some point within the ventricular system, preventing it from reaching the subarachnoid space for absorption. The classic example is aqueductal stenosis, where the narrow aqueduct of Sylvius becomes blocked, causing the lateral and third ventricles to dilate proximal to the obstruction. The second major category is communicating, or non-obstructive, hydrocephalus. Here, the ventricular system itself is patent, and CSF can flow freely into the subarachnoid space. The problem lies outside the ventricles, either with impaired flow through the subarachnoid cisterns or, more commonly, with dysfunctional absorption at the level of the arachnoid villi. This is often the result of scarring and inflammation following a subarachnoid hemorrhage or meningitis. A much rarer form is hypersecretory hydrocephalus, where the issue is not obstruction or impaired absorption, but rather an overproduction of CSF, most classically caused by a choroid plexus papilloma. The etiology of hydrocephalus is vast and can be broadly divided into congenital and acquired causes. Congenital hydrocephalus is present at birth and results from insults or malformations occurring during fetal development. By far, the most common cause is aqueductal stenosis. This can be an isolated developmental anomaly, sometimes inherited as an X-linked recessive trait associated with mutations in the L1 gene, or it can be the result of in utero infections or hemorrhage leading to scarring, or gliosis, of the aqueduct. Another major group of congenital causes involves the Chiari malformations, which are structural defects in the cerebellum and brainstem. The Chiari-2 malformation is almost universally associated with myeloma meningocele, a type of neural tube defect. In this condition, the cerebellum and brainstem are displaced downward through the foramen magnum, crowding the posterior fossa and obstructing the outflow of CSF from the fourth ventricle, leading to hydrocephalus in over 80% of affected infants. The Dandy-Walker malformation is another important congenital cause. It is defined by a classic triad of findings: a cystic dilation of the fourth ventricle that fills most of the posterior fossa, complete or partial agenesis of the cerebellar vermis, which is the central part of the cerebellum, and an enlarged posterior fossa with upward displacement of the tentorium. This malformation directly obstructs the foramina of Luschka and Magendie, preventing CSF from exiting the ventricular system. Other central nervous system malformations, like a vein of Galen malformation, a type of arteriovenous malformation, can also cause hydrocephalus, typically through a compressive effect on the aqueduct of Sylvius. Acquired hydrocephalus develops after birth as a result of a new insult to the central nervous system. The most common causes in the pediatric population are post-hemorrhagic and post-infectious. Post-hemorrhagic hydrocephalus is a major complication in premature infants who suffer an intraventricular hemorrhage, or IVH. The presence of blood and its breakdown products within the CSF incites a significant inflammatory response. This leads to fibrosis and scarring, or arachnoiditis, within the subarachnoid space and at the arachnoid villi, impairing CSF absorption and causing a communicating hydrocephalus. Post-infectious hydrocephalus follows a similar principle. Bacterial meningitis, particularly with pathogens like Streptococcus pneumoniae or Mycobacterium tuberculosis, can produce thick, purulent exudates in the basal cisterns. The subsequent inflammatory response and scarring process can block CSF pathways, leading to a communicating hydrocephalus. Ventriculitis, an infection within the ventricles, can also lead to scarring and obstruction of the aqueduct, causing an obstructive hydrocephalus. Brain tumors are another critical acquired cause, especially in older children. Tumors located in the posterior fossa, such as medulloblastomas, ependymomas, and cerebellar astrocytomas, frequently cause obstructive hydrocephalus by compressing the fourth ventricle or the aqueduct of Sylvius. Suprasellar tumors, like craniopharyngiomas, can grow to obstruct the foramina of Monro. Finally, head trauma can lead to subarachnoid hemorrhage, which, similar to IVH in neonates, can result in a communicating hydrocephalus. The incidence of congenital hydrocephalus is estimated to be between 1 and 3 per 1,000 live births, making it one of the more common congenital anomalies. The clinical presentation of hydrocephalus is highly dependent on the child's age, the acuity of onset, and the underlying cause. The signs and symptoms are largely driven by the effects of increased intracranial pressure on the developing brain, but the compliant, unfused skull of an infant creates a very different clinical picture from that of an older child with a fused, rigid cranium. In infancy, particularly in the first few months of life, The cardinal sign of hydrocephalus is an accelerated rate of head growth. It is crucial to understand that it is the velocity of growth, not simply a single large measurement, that is most concerning. A head circumference that rapidly crosses percentile lines on a standardized growth chart is a major red flag. This cranial expansion is a compensatory mechanism. The infant's open fontanelles and unfused sutures allow the skull to expand to accommodate the increasing CSF volume, temporarily buffering the rise in intracranial pressure. On physical examination, this manifests as a tense, full, or overtly bulging anterior fontanelle that lacks its normal pulsations. The cranial sutures may feel widely split or separated on palpation. A classic, though less common, sign is the mace-wand sign, or the cracked pot sound, which can be elicited by percussing the skull over a separated suture. The scalp itself may appear thin and shiny, with visibly dilated scalp veins, a result of venous congestion. Ocular signs are also prominent. The setting sun sign is a classic finding, characterized by a persistent downward deviation of the eyes. This is caused by pressure from the dilated suprapineal recess of the third ventricle on the tectal plate of the midbrain, which controls vertical gaze. Palsies of the sixth cranial nerve, the abducens nerve, are also common due to its long intracranial course, leading to an inward deviation of one or both eyes, a condition known as esotropia, and subsequent diplopia. The general symptoms in an infant are often nonspecific but reflect cortical irritation and brainstem dysfunction from rising ICP. These include excessive irritability, a high-pitched, shrill cry, poor feeding, recurrent vomiting which may become projectile, and increasing lethargy or sleepiness. In an older child, after the cranial sutures have fused, typically around 2 years of age, the skull can no longer expand. Therefore, the clinical presentation is dominated by the direct symptoms and signs of increased intracranial pressure. Headache is the most common and often the earliest symptom. These headaches have characteristic features. They are typically worse in the morning upon waking, and are exacerbated by activities that further increase ICP, such as coughing, sneezing, or a Valsalva maneuver. Nausea and vomiting, especially in the morning without preceding nausea, are also highly suggestive. Ophthalmologic signs are critical in the older child. Papilledema, which is swelling of the optic disc due to increased pressure transmitted along the optic nerve sheath, is the hallmark sign. It is rarely seen in infants because their open sutures decompress the pressure. Early papilledema may be asymptomatic, but as it progresses, it can cause transient visual obscurations, an enlarged blind spot, and eventually, if left untreated, progressive visual field loss and irreversible optic atrophy leading to blindness. Blurring of vision and diplopia from sixth nerve palsies are also common complaints. As ICP continues to rise, more global neurological and cognitive changes emerge. Lethargy, apathy, and changes in personality or behavior become apparent. A notable sign is a decline in school performance, which may be the first clue for parents and teachers. Gait disturbances can also develop, often described as a broad-based, unsteady, or magnetic gait, where the child seems to have difficulty lifting their feet from the floor. In some cases, pressure on the third ventricle and hypothalamus can disrupt the endocrine axis, leading to conditions such as precocious puberty. If hydrocephalus is left untreated in this age group, the child will progress to obtundation, coma, and eventually death from brainstem herniation. The diagnostic workup for a child with suspected hydrocephalus hinges on a meticulous history and physical examination, confirmed and characterized by neuroimaging. The clinical assessment is the first and most vital step. For infants, this involves serial measurements of the occipitofrontal head circumference plotted on a standardized growth chart. As we discussed, an accelerated growth velocity is the most sensitive indicator. A thorough neurologic examination is essential to identify signs like a bulging fontanelle, split sutures, the setting sun sign, or cranial nerve palsies. In older children, the focus is on identifying the signs of increased intracranial pressure, with a fundoscopic examination to detect papilledema being absolutely mandatory. Neuroimaging is the cornerstone for confirming the diagnosis, defining the extent of ventriculomegaly, and, most importantly, identifying the underlying etiology. The choice of modality depends on the patient's age and the clinical context. In an infant with an open anterior fontanelle, cranial ultrasonography is the ideal initial imaging study. Its advantages are numerous. It is non-invasive, portable, does not use ionizing radiation, and can be performed at the bedside without sedation. Ultrasound provides excellent visualization of the lateral and third ventricles, allowing for accurate measurement of ventricular size and detection of intraventricular hemorrhage. However, its limitations are also significant. It provides a poor view of the posterior fossa and the cerebral convexities, and the image quality is highly operator dependent. Computed tomography, or CT, has a primary role in the emergency setting. It is rapid and widely available, making it the modality of choice for a child presenting with acute neurological deterioration. CT is excellent for detecting acute hemorrhage, demonstrating the presence and severity of hydrocephalus, and identifying skull fractures or large tumors. A non-contrast CT is sufficient to show ventriculomegaly and hemorrhage, while a contrast-enhanced study can help delineate tumors or abscesses. The major drawback of CT is its use of ionizing radiation, a significant concern in the developing pediatric brain. Magnetic resonance imaging, or MRI, is unequivocally the gold standard for the comprehensive evaluation of hydrocephalus. It offers superior anatomical detail without ionizing radiation. MRI is the best modality for precisely identifying the cause of hydrocephalus, whether it's a subtle congenital malformation, a tumor, or scarring from a prior insult. Different MRI sequences provide unique information. T2 weighted images are excellent for showing the enlarged, CSF-filled ventricles and detecting areas of periventricular edema, often called transependymal flow, which indicates high-pressure hydrocephalus. FLAIR, or fluid attenuated inversion recovery, sequences are useful for highlighting parenchymal abnormalities adjacent to the ventricles. T1 weighted images provide excellent anatomical detail, clearly showing structures like a thinned and stretched corpus callosum. Specialized high-resolution sequences, such as CISS or FIESTA, can visualize the aqueduct of Sylvius with exquisite detail to confirm or exclude stenosis. Furthermore, MR venography, or MRV, can be performed to rule out a dural venous sinus thrombosis as a cause of impaired CSF absorption. Classic MRI findings of hydrocephalus include disproportionate enlargement of the temporal horns of the lateral ventricles, an upward bowing and thinning of the corpus callosum, and effacement of the cortical sulci. A lumbar puncture, or LP, and CSF manometry play a specific but limited role in the workup. The primary purpose of an LP is diagnostic, to analyze the CSF for evidence of infection or hemorrhage. However, it is absolutely critical to remember that performing an LP is contraindicated in a patient with suspected obstructive hydrocephalus before neuroimaging has been done. Removing CSF from the lumbar cistern in the presence of a proximal obstruction can create a pressure gradient that leads to catastrophic downward brainstem herniation. CSF manometry, which measures the opening pressure, is essential for diagnosing communicating forms of intracranial hypertension, most notably idiopathic intracranial hypertension, or IIH, which is an important differential diagnosis. A pressure greater than 28 centimeters of water is generally considered elevated in a relaxed, properly positioned child. Finally, a comprehensive differential diagnosis is crucial. Not everything that looks like hydrocephalus is hydrocephalus. A common mimic in infants is benign external hydrocephalus, also known as benign enlargement of the subarachnoid spaces of infancy. These infants present with macrocephaly, but imaging reveals prominent frontal subarachnoid spaces with only mild to normal ventricular size. This is a self-limiting condition that typically resolves without intervention. Another important entity is hydrocephalus ex vacuo, where the ventricles appear large not due to increased pressure, but due to a loss of surrounding brain tissue, or cerebral atrophy. This is seen after severe hypoxic ischemic injury. CSF pressure is normal, and treatment is not indicated. Megalencephaly, or a truly large brain, must also be considered. This can be familial or part of a genetic syndrome like Sotos syndrome. Here, imaging shows increased brain parenchyma, not just increased CSF volume. Other differentials include chronic subdural hematomas or hygromas, which can expand the intracranial volume and mimic the symptoms of hydrocephalus. The management of pediatric hydrocephalus is aimed at a single primary goal: to safely and effectively normalize intracranial pressure, thereby halting progressive ventricular enlargement and preserving brain function. While medical therapies have a role, the definitive treatment for clinically significant hydrocephalus is almost always surgical. Medical management is generally considered a temporary or adjunctive measure. It is most often employed as a bridge to surgery or in specific situations like the slowly progressing post-hemorrhagic hydrocephalus of prematurity. The strategy is to decrease the rate of CSF production. The medications most commonly used are acetazolamide, a carbonic anhydrase inhibitor, and furosemide, a loop diuretic. Acetazolamide directly inhibits the carbonic anhydrase enzyme in the choroid plexus, which is critical for CSF secretion. Furosemide has a weaker effect but can act synergistically. However, their long-term efficacy is limited, and they are associated with significant side effects, most notably metabolic acidosis and electrolyte disturbances, which can be particularly problematic in fragile, premature infants. Another temporizing measure, also used primarily in premature infants with post-hemorrhagic hydrocephalus, is serial lumbar or ventricular punctures. By repeatedly removing small volumes of CSF, one can temporarily control intracranial pressure, allowing time for the infant to grow and become a better candidate for definitive surgery, or in some cases, allowing for spontaneous resolution as the CSF absorption pathways mature or clear. Surgical intervention represents the mainstay of treatment and primarily involves diverting the excess CSF to another body cavity where it can be absorbed. The workhorse procedure for the last several decades has been the placement of a ventriculoperitoneal shunt, or VP shunt. A VP shunt is a deceptively simple-looking device consisting of three main components. First, a proximal, or ventricular catheter, which is a thin tube inserted into one of the lateral ventricles of the brain. Second, a one-way valve, which is placed subcutaneously, usually behind the ear. This valve is the brain of the system. It is designed to open and allow CSF to flow out only when the ventricular pressure exceeds a certain predetermined level. There are various types of valves, including fixed pressure valves and programmable valves that can be adjusted non-invasively with an external magnetic device. Many valves also incorporate an anti-siphon device to prevent overdrainage when the patient is upright. The third component is the distal catheter, a long tube that is tunneled under the skin from the valve down to the abdomen, where its tip is placed into the peritoneal cavity. The peritoneum has a vast surface area and is highly efficient at absorbing the diverted CSF. While the peritoneal cavity is the most common destination, the CSF can also be shunted to the right atrium of the heart, known as a ventriculoatrial shunt, or to the pleural space, a ventriculopleural shunt, though these are less common. While VP shunts can be life-saving, they are notoriously prone to complications, which is a high-yield topic for any resident to master. The most serious complication is shunt infection. This typically occurs within the first few months after surgery and is most often caused by skin flora, particularly Staphylococcus epidermidis, introduced at the time of insertion. A shunt infection can present with fever, signs of meningitis, or abdominal symptoms like pain and tenderness if a peritoneal pseudocyst forms. The management is rigorous and requires complete removal of the infected shunt, placement of a temporary external ventricular drain to control the hydrocephalus, a course of intravenous antibiotics, and finally, insertion of a new shunt once the CSF is sterilized. The most common complication overall is shunt malfunction due to obstruction. The blockage can occur at any point. The proximal catheter can be clogged by choroid plexus or cellular debris, the valve mechanism can fail, or the distal catheter can become blocked, kinked, or migrate out of the peritoneal cavity. The clinical presentation of a shunt malfunction is a recurrence of the original symptoms of hydrocephalus. Diagnosing a malfunction involves a combination of clinical suspicion, imaging like a CT scan to look for increased ventricle size, and often a shunt series of plain X-rays to check for mechanical integrity. A shunt tap, where a needle is inserted into the valve reservoir to measure pressure and assess flow, can also be diagnostic. Overdrainage is another significant problem, which can lead to slit ventricle syndrome and subdural hematomas. When too much CSF is drained, the ventricles can collapse into small, slit-like spaces. This can cause intermittent obstruction of the ventricular catheter, leading to severe headaches, particularly when the patient is upright. The negative intracranial pressure can also tear bridging veins, resulting in subdural hematomas. An alternative surgical approach that avoids the long-term complications of a shunt is the endoscopic third ventriculostomy, or ETV. This is a minimally invasive procedure where a neuroendoscope is passed into the ventricular system. Under direct vision, a small opening, or fenestration, is created in the floor of the third ventricle. This allows CSF to flow directly from the third ventricle into the prepontine cistern, one of the large subarachnoid spaces at the base of the brain, thereby bypassing the point of obstruction. ETV is most effective for purely obstructive hydrocephalus, such as that caused by aqueductal stenosis or a posterior fossa tumor. Its success is less predictable in communicating hydrocephalus or in very young infants, generally those under 6 months of age, in part because their CSF absorption pathways may not be fully mature. The ETV success score is a validated tool that can help predict the likelihood of success based on age, etiology, and prior shunt history. While ETV avoids the hardware-related complications of a shunt, it has its own unique risks, including hemorrhage from injury to the basilar artery, damage to the hypothalamus or other critical structures near the floor of the third ventricle, and late failure if the stoma scars over. A more recent evolution of this technique, particularly for infants, is ETV combined with choroid plexus cauterization, or CPC. This dual approach attacks the problem from both sides. The ETV creates a new outflow pathway, while the CPC reduces the amount of CSF being produced. Landmark trials, particularly from work in Uganda, have shown this combination to be highly effective, reducing the need for shunt placement in a significant portion of infants. As our understanding of hydrocephalus deepens, several areas of special interest, controversy, and active research have come to the forefront. One of the most challenging clinical scenarios is post-hemorrhagic hydrocephalus of prematurity. As we've discussed, this condition arises from blood products in the CSF triggering inflammation and fibrosis, leading to a communicating hydrocephalus. The management is contentious. These infants are often too small and fragile for immediate VP shunt placement. The traditional approach involves temporizing measures like serial lumbar punctures or placement of a ventricular access device for intermittent CSF tapping, with the hope that the hydrocephalus will resolve or that the infant will grow large enough for a shunt. A landmark clinical trial known as the DRIFT trial, which stands for drainage, irrigation, and fibrinolytic therapy, investigated a more proactive approach. The study randomized premature infants with post-hemorrhagic ventricular dilation to either standard care or a protocol of ventricular lavage with a fibrinolytic agent to wash out the blood products and reduce inflammation. While the trial did not reduce the ultimate rate of shunt dependency, it did show a significant reduction in severe cognitive disability at 2 years of age, suggesting a potential neuroprotective benefit of clearing the toxic blood products from the ventricular system. The debate over the optimal timing and method of intervention in these vulnerable infants continues and is a major area of ongoing research. Another concept worth mentioning is arrested hydrocephalus. This describes a state where a patient, typically with congenital hydrocephalus, reaches an equilibrium. Their ventricles remain enlarged, but intracranial pressure normalizes, and their head growth proceeds parallel to the standard curves. For many years, these patients were thought to be stable and not require intervention. However, it is now recognized that this equilibrium can be fragile. A minor head injury or illness later in life can disrupt the balance, leading to a sudden and dangerous decompensation with acute rises in intracranial pressure. Therefore, the concept of a truly arrested and benign hydrocephalus is now viewed with much more caution. The field is also witnessing exciting progress in research and technology. There is a continuous effort to develop better shunt technologies. This includes smart valves that can sense and adapt to the patient's posture and activity level, as well as catheters impregnated with antibiotics or coated with materials that resist biofilm formation to reduce the risk of infection. There will be no this inserted audio clip if you buy the software license key or activation key. On the molecular front, researchers are investigating medical therapies that could more effectively target the ion channels and transport mechanisms involved in CSF secretion. There is also intense interest in understanding the cellular and molecular pathways that drive the fibrotic, scar-forming process after hemorrhage and infection. Identifying key inflammatory mediators could open the door to targeted anti-inflammatory or anti-fibrotic therapies that could prevent the development of hydrocephalus in these high-risk settings. Finally, a crucial area of research is focused on neuroprotective strategies. Hydrocephalus is not just a plumbing problem. The persistent pressure and stretching of brain tissue causes secondary ischemic and metabolic injury to neurons and axons. Research into therapies that can mitigate this secondary injury, independent of controlling the pressure itself, holds great promise for improving long-term cognitive and neurological outcomes for these children. The ultimate goal is to move beyond simply diverting fluid to actively protecting and preserving the developing brain. As we conclude this comprehensive review of pediatric hydrocephalus, let's distill our discussion into a few key take-home points that are essential for every clinician. First, remember that hydrocephalus is the final common pathway for a wide array of pediatric central nervous system insults, fundamentally resulting from an imbalance between CSF production and absorption. A timely and accurate diagnosis, driven by clinical suspicion and confirmed with neuroimaging, particularly MRI, is absolutely crucial to prevent long-term neurological damage. Second, the clinical presentation is highly age-dependent. In infants with open sutures, the most reliable sign is an accelerated head growth velocity and a tense, bulging fontanelle. In older children with fused skulls, the presentation shifts to the classic signs of increased intracranial pressure, such as morning headaches, vomiting, and, critically, papilledema on fundoscopic examination. Third, the mainstay of treatment is surgical CSF diversion. The ventriculoperitoneal shunt remains the most common procedure, but it is a device fraught with potential complications, most notably infection and obstruction. Always maintain a high index of suspicion for shunt malfunction in any shunted patient who presents with new, recurrent, or even vague neurological symptoms. Fourth, endoscopic third ventriculostomy, especially when combined with choroid plexus cauterization in infants, represents an excellent alternative for obstructive hydrocephalus. It avoids the long-term, hardware-related complications inherent to shunts and should be considered a primary option in appropriately selected patients, particularly in children older than 6 months with aqueductal stenosis. Finally, managing hydrocephalus is a long-term commitment. It requires a multidisciplinary approach and vigilant follow-up to monitor for complications and address the complex neurodevelopmental, cognitive, and social challenges that these children often face. Our role extends far beyond the initial diagnosis and surgical intervention to encompass lifelong support for the patient and their family. Thank you for joining us for this in-depth exploration of pediatric hydrocephalus. We hope this discussion has provided you with a robust framework for understanding, diagnosing, and managing this complex and important condition.